Well, hello, good evening, and welcome to the Institute of Healthcare Management's latest in its virtual HealthChat series. And this evening, we are absolutely thrilled and privileged indeed to welcome the fabulous team from St Helens and Knowsley Hospitals NHS Trust. We have Marr, the Chief Executive, who's also during the recent COVID pandemic been the Cheshire and Merseyside Hospitals Cell Commander. We also have Rowan Pritchard-Jones, who's the Medical Director at Centre of Operations. And of course, in the chair, asking all the questions, helping the conversation to move along, we have the fabulous Roy Lilly. So without further ado, thank you for joining us this evening. I'm going to hand on to Roy. Thank you.
John, thank you very much for that introduction, and good evening and welcome everybody watching. We hope we're going to find lots of things to interest you, and if you've got any questions, make a note of them, because at the end John will be saying, send us the questions so that we can send them directly to Anne and her colleagues. So we'll talk to Rowan and Rob in a minute or two, but just to come to you, Anne, first to set the scene. I have to say, of all the job titles that I've ever seen in the NHS, the one, I've had a few myself, the one I am most envious of is Cell Commander, which is brilliant. What is a Cell Commander?
Well, one of the disappointing things, Roy, is that you do get a load of royal gold braid to wear and some sparkly diamonds to go with the title, although the word cell is a bit concerning, isn't it? But yeah, so the idea was of having the cells as a hospital cell and an out-of-hospital cell was to coordinate all of the efforts of all of the various organisations in Cheshire and Merseyside, of which there are many more per head or whatever than there would be in many of the other health systems around the country. So, you know, whilst we've made some progress in coordinating what we do as a system, you know, we've still got lots of different separate organisations, and the idea was that this was something we needed to handle collectively. And so I was given the chalice of being the cell.
I'm just sorry you haven't got a uniform. I'm really
No, I did ask. I have asked for the gold braid to go with it, but it hasn't been forthcoming now. But
well, I think we're gonna have to try and see if we can fix that. So I suppose really, I mean, the one thing that's come to my mind whilst all this has been going on is the need to sort of, as much as hospitals have turned themselves inside out to make this work. The organisational structures really haven't been robust in the way that they needed to be. Is this sort of to recreate something close to what some of us will remember as a regional health authority? Is that the sort of thing?
Obviously, we've, you know, over the past few years tried to find ways to, you know, to move away from that whole principle of competition and towards collaboration. And then, if we didn't have enough incentives with the financial issues and the workforce issues, you know, they throw a pandemic at us to further encourage the notion that, you know what, it's a lot better if you work together than if you work separately. And I suppose in the first instance, the big issue was, you know, we're behind. You know, Britain's behind Italy. The Northwest is behind London. So we're all watching what's happening in Italy, and then we're all watching what's happening in London. And kind of doing the mathematics of what does that mean in terms of pressure on intensive care. And so, you know, quite clearly we were started to talk about, you know, we need 7 times as many intensive care beds. Then it went down to 5 times as many intensive care beds. And of course, that is just such an enormous figure to even contemplate. And of course, one of the other complications we've got on our patch is having all these specialist trusts where many of the intensive care beds are actually based. So there was certainly an urgent need for us to really pool our resources. We didn't so much move workforce around, but what we did do was mutually aid each other in terms of moving some cases around, because we moved some cases away from hospitals with A&E departments who were going to get the new cases in. So cases where we could choose which patients were best transferred to one of the cold specialist sites. We were able to do that. We were able to share PPE. We had mutual aid going on in terms of PPE,
Yeah,
but also.
I heard you had a WhatsApp group going at one stage too.
Oh yeah, it's still going on, yeah. And we've got, like, what we've done is we've kind of got minimum amounts of PPE per site against how much PPE we've got, and therefore we've got a kind of formal mutual aid thing going on, but also around things like, some of the drugs and other supplies as well, and things like renal replacement therapy capacity, because that's it. That also
the kit for that, everybody thinks all ventilators, but of course
no, it's more complicated.
So I know there was a problem with the renal dialysis kit.
Yes, very much so, and that's why we were moving patients around. So the fact that we got to that point where we were really, it was a shared resource across the whole of the patch, both in terms of moving the patients to somewhere that was better able to cope with them, and moving the stuff around, the supplies, the PPE, to wherever we needed them to be in order to get the best combination of facilities for the patients that we had.
Yeah. What about social care? And we know you had to decant pretty quickly a lot of patients into care homes and so on, and that's its own story, and probably a story for another time. But how did you get on with social services whilst all this was happening, or did you just deal directly with the care homes?
Well, you do a bit of both, isn't it? And we've got loads of different boroughs, and you get a slightly different model in every different borough. So some places are quite joined up, some places aren't joined up at all. So it was a question of us feeding into the particular local boroughs, and so at the best, what happened was we were able to send frailty teams into the care homes.
Now that's important, because let's just linger for a moment on that, because now it's reported in the press, I don't know if it's true, but it's reported in the press that there is a frailty team and a clinical frailty team in every care home, which sounds to me like a big ask. I don't know if it's true or not. But that's made the big difference, isn't it? Because the care homes are, the answers, it's over the door. It's a care home. It's not a nursing home. And suddenly we had to make them all nursing homes.
Yeah, because it was the scale. I talk about the scale of the challenge for the NHS. The scale of the challenge for the social care sector, without the infrastructure that's available to us, all these different organisations, without the size to be able to employ all kinds of infection control specialists and clinical specialists, be they doctors or nurses, every type of clinical specialist. Some of them were dealing with really sick patients with an unknown illness. It's been bad enough for us with this illness being so unpredictable, and we've learned new things about it, kind of every day. Yeah. To put that into a care home setting whereby you've got the most vulnerable patients and, staff who are, not equipped in terms of expertise, in terms of PPE and things like that. So, I don't think in our patch it was as bad as it was in some patches, because we were able to provide that support. But the idea that you can provide that kind of input is invaluable, but of course constrained at times by what staff there are available to us all. And
to be fair to care homes, 2/3 of care homes haven't had any cases.
Exactly, which is absolutely fabulous that they haven't had any cases. All credit them.
Listen, let's look for a moment. I'm conscious of the time. What are you most proud of so far?
Well, one of the things I thought I'd like to share with people was like, what is it that what have we learned as managers, from this, as opposed to what have the clinicians learned? So I suppose it was like there's 4 things I wanted to sort of highlight. One was that we already thought our staff were absolutely amazing, and now we're even more impressed. I already said they were amazing, but this, everyone's being told to stay at home and stay safe, and our staff are being asked to go into this, absolutely unprecedented and uncertain environment. They didn't know what they were going into face when all this kicked off. It was like nothing we'd ever seen before. And the way the staff did it with huge courage, but also huge compassion for the patients. I am just totally in awe of those people who did that. And I'd say that about the social care staff as well as the healthcare staff. But, the ones I've seen here, up close, it's just, it takes it to an even higher level in terms of my admiration for the selflessness and the courage of the people who've dealt with this crisis.
Yeah.
The second thing I'd just like to say is what we said before about, it's cemented the fact that we're better together, i.e. organisations working in support of each other, not in competition with each other. We always knew, didn't we, that made more sense. And I think we've demonstrated through the way we've handled this just how much more sense it makes, especially in a place like Cheshire and Merseyside, where our fragmentation is probably more than other places because of the small and many organisations. A really important point, I think, is the way we're so often, as the NHS or the health sector, compared unfavourably with other industries in terms of us being able to, step up things, change things, move quickly, be agile. And yet, just think of all those things we changed in literally 2 minutes. No more can we have other sectors held up against us as being much more capable than we are, because I just think we performed a miracle to change, to train all those people to suddenly become intensive care people, doctors, nurses, whatever, to change all the shifts, all the training, all the rotors, all the configuration, all in a couple of weeks. It was just absolutely massive. So I don't think any of these outside people can say, the NHS couldn't perform even better than the best when it came to meeting a challenge head on, when we were given the conditions to do it, and we were given the conditions to do it. And the last thing I'd just like to say is the very value that the public has demonstrated that they've now placed on the NHS can never be taken away from us, forevermore. It's been acknowledged really publicly, clearly and emphatically that the public really values the NHS, and that can never, ever be in doubt again.
No, I think that's, you're so right. So the staff, we're better together, compare with other industries and public values. They're 4 really very strong themes, and thank you for that. And I have to tell you that on a personal note, I mean, people well know that I live in Surrey, but for the early on, I moved to London because I was very isolated where I was in Surrey. And I live in an apartment block on the river. I'm very privileged. But the first Thursday night I was here, it's a very multicultural place here. It's fantastic. It's vibrant. I love being here. Lots of young families from all over the world. The first Thursday night, I went out on the balcony, and everyone here was out on their balcony from all over the world, banging saucepans and clapping. And, it moved me. I still get emotional telling you about it. It moved me to tears. I did not expect it. I wouldn't have seen it, sorry, because I'm miles from anywhere. But here, it was just such a moving thing. And you are right. I think the NHS in the nation's esteem has really gone up. So those are 4 really very good things. Shall we move on and now to talk to some of your colleagues? You talked about so kind of reorganising the place. So why don't we? Let's talk to Rowan Pritchard-Jones, your medical director, who of course has had one of the easiest jobs in the world while all this is going on. There's no elective work to worry about. There's no question of getting people home on time. So how have you been spending your time, Rowan?
Well, there's been a thing or two to do. There's no doubt it's been an even more interesting start to my journey, having been a medical director for only 6 months. We have had...
It's a real baptism of fire, isn't it?
If you knew in September that which you know now. Anyway, the answer to that question, genuinely, is I would always take this on because we are so fortunate where we are that the teamwork that drives this forward has been superb. And collaboration has been a central theme as medical directors. So within the trust, there's a number of things that we've done at pace in order to support working differently. We've used existing technology and perhaps repurposed it a bit. We've rebranded it quite a lot, and our patients have embraced it. From the humble telephone has worked incredibly hard, through to the telehealth, which has always a bit of a challenge to get in, has sort of found its niche. And our ability to be efficient with one-stop approaching, where sometimes someone would come for a consultation and then we'll book some investigations, and that might lead to some sort of an operation. Our ability to do things in one stop has been tremendous.
Can I just ask you to hang on for that second, because I'd like just to tease a bit more out about that, because I mean, I've been around the NHS for 40 years, nearly 50 years now, but I've seen more progress with the use of IT and technology in the last last probably 3 months than I've seen in the last 50 years. I mean, how, and I have to kind of put this delicately. I mean, not all of your colleagues have embraced the use of technology in the past, but suddenly there was this kind of Damascus Road conversion to like everybody's online now. What happened?
I think an unprecedented pressure was brought to bear upon us that had two things. It said, we cannot have patients in this hospital unless they absolutely need to be here.
Yeah.
Coupled with this intrinsic bit in the middle of all of us doctors, which is, I need to care for my patients. And the only way to do that was to get smart about working remotely wherever you can. And as much as I would say there was some inertia to overcoming clinicians embracing technology, the same potentially used to be true of patients. The reaction of patients having individual phone calls with their consultants or specialist nurses has been superb. And where we worried that will patients cope with having a video conference, you know what, they've gone on and done it. Even our more mature patients, our silver surfers, have embraced working.
Be careful.
And many will not want to go back. It's been such a good quality way of doing things. I think there's been an arrogance in healthcare previously that we must always expect the patient to come to us.
Yeah, I love that phrase, no going back, because Dr. Terry Porritt, who you know, Terry, is running the Academy of Fabulous Stuff, and she's got a campaign going now, no going back. And we've been inundated with people saying, this is stuff we're doing and we're not going back, you know, whatever happens. So it's that was really quite interesting.
And certainly with no clear end game out with this, we've just got to cement these things into becoming are closer to business as usual.
Absolutely must. I'm just going to push on, if I may. Forgive me cutting across you. But I also wanted to ask you about the actual treatment of patients with CV19. I mean, there wasn't really a great clarity of treatment at the beginning. And there were a number of WhatsApp groups that people kindly let me into as a non-clinician, just as an observer. And you could see how the clinicians were saying, well, we should try this and we should try that. And then, you know, intubation wasn't a great idea if you could use a pressurized mask. Some of the drugs they stopped using because they were too invasive. I mean, that interested me, that this whole treatment regime just emerged remotely with people sharing stuff. And I thought it was fantastic.
And collaboration with that has been astonishing. I've probably read more papers, and this is me speaking to you as an academic surgeon. I've probably read more papers in the last 8 weeks than I had in 6 months before that. And the sharing, the interpreting, the suggesting, and reflecting on outcomes and sharing all of that has been absolutely superb. And it's meant we've moved kit around. My goodness me, the way we've moved patients around, even the mutual aid where pressure's been brought to bear has been astonishingly good. Yes, we've worked creatively, and perhaps some of the barriers to innovation have dropped. It still demands that thought towards the governance and do it properly and being the best of ourselves every day in what we do. But it has given space to work differently. And I've certainly had astonishing colleagues who have gone far above and beyond in order to provide innovative solutions to our patients.
I think it's astonishing. I'm going to come back to you, Rowan, if I may, because I know there's more things that you'll want to share with us. But let's move on to Rob. I've lost Rob off my screen. I hope he's there somewhere.
Hi, I am here.
There you are, Rob. Hi, good evening. Hello, Rob. Sorry, I missed you for a moment. I mean, okay, fine. So you must have done something bad in a previous life to end up being the director of operations and performance at a time like this. I mean, that was the big nut to crack, wasn't it? You know, how you reconfigured. The physical reconfiguring of the place. Yeah. It's not just the man. I mean, physically getting porters and people in to reconfigure. How did you approach that?
I mean, I suppose we approached it in a way that we always do, and that is through that teamwork. And the command and control element of that was really important. So actually getting together really early with the teams, all the senior teams, but equally with all of the individual wards and departments, just to kind of describe what it is that we were trying to achieve. So it was really important very early on to be able to communicate effectively with the teams. And obviously our comms team have been really important in that, so that we've been sending really clear messages. So
well, let's hear it for the comms team.
Absolutely.
Comms team, everyone. Well done, the comms team. Yeah.
Well done, the comms team.
Yeah, they'll be pleased for that. Yeah.
Yeah. So it was really important to get everybody together in that kind of early approach, because it was a significant amount of work. And I suppose some of the easy bit is around stopping some of the lists and stopping some of the work, because you can just say, we're not going to go ahead and do that list next week, etc. The really difficult part is actually getting everybody together into the right sort of forum to bring that capacity together in the hospital.
So what did you do? Did you kind of sit down on a whiteboard with everybody with a whiteboard and say, okay, what have we got to do? I mean, it's such a gigantic problem to reconfigure a hospital, which you did, I know, in pretty much a weekend. I mean, I'm interested, from the management point of view, how did you do that?
So we did that. I mean, I've got a fantastic team. So we've mentioned a lot of the clinical staff and the people who've been so fantastic in providing the care to the patients. But I have to mention the operational management team that worked throughout the organisation, because we couldn't have done it without them. And it was absolutely about the operational management team bringing that plan together for the organisation. And so we had to be really clear about what we did from a very early stage. We emptied a huge number of wards to be able to re-provide the staff to create what at first we thought was going to be well over 100 critical care beds. Yeah. And when we're coming from an organisation where we're commissioned for 14 beds, that's a significant amount of work to be able to achieve.
Exactly. And nationally, only 80% of intensive therapy beds are ever occupied at any one time. So we've gone from probably 8 or 9 patients to 10 times that.
Yeah, and I think alongside that, we had to think about equipment. So this was about equipping the beds and having all of the right ventilators, pumps, etc. around it. We had to think about also staffing those cohort wards. So it wasn't just about intensive care. It was about also giving support to those wards that were going to see a high number of COVID positive inpatients. And that's been really difficult as well. So a real challenge for those sorts of wards and departments.
What about the estates guys? We'll give the estates guys a mention, because they were the ones who were finding the oxygen, weren't they? I mean, we just come in normally, we just, oxygen, you just kind of plug it in the wall. But all of a sudden, you've got 100 times the demand, you plug it in and the pressure drops. I mean, they did a great job, didn't they?
They did a fantastic job, and it wasn't just about that oxygen supply, because obviously we were all really concerned about that and trying to work out how much we were using, how much we had, how long we had to be able to deliver that oxygen supply directly to the patients. But it was also about physical reconfiguration. So, I mean, our estates team got doors across resource cubicles in A&E within a matter of days. They were moving things around in terms of the estate. They were giving us the ability to be able to provide care in areas, critical care, level 3 sort of intensive care in areas that we hadn't done previously. Yeah. So all of that, absolutely.
Places you didn't know existed.
Yeah, absolutely.
Yeah, I think it's a wonderful story, and I mean it's been a human tragedy, of course, and we can't ever forget the damage it's done to families, and who knows their mindset for years to come. But in terms of the management of a problem, this is in D-Day, I think, proportions really. I'm conscious of the time, and I'll come back to you. I mean, of course, what we're thinking about now is really what comes next. Mm-hmm. I'd like just to touch on what the new normal will look like. But before I get to that point, perhaps you could just give us a word on sort of the restoration and recovery, because now the pressure's on with, I don't know, who knows, 5 million people waiting for a hip operation or whatever, God knows, I hate to think what the figure is. I mean, are you inching towards the recovery?
Yeah, so obviously the first thing we've got to do is this kind of, let's call it the restoration plan, which is to just get things going again. And then the next phase after that will be more of a recovery plan. But so the restoration plan part of it, again, it's been produced for the whole of Cheshire and Merseyside and then put into a whole Northwest plan. And some of the challenges are things like, you know, how can you possibly be in any way efficient if you've got to do social distancing, you know, in clinical spaces, and all of the additional cleaning that's required. You know, if you get a patient that we don't know if they're positive or negative in a CT scanner, then, you know, the cleaning of the CT scanner and therefore how much reduce the capacity, the air changes in theatres in between cases, and on it goes. And, you know, making sure we've got the right PPE, because that story's not over yet. We're still anxious about whether or not we'll start things up and then we won't have enough PPE for the various different procedures we've got to do. So there are all kinds of problems, and also, you know, the fragility of the social care sector in terms of being able to discharge. We're being told to keep our occupancy levels much lower than our usual sort of 100% that we'd normally have, to get it down to something like 80%. Well, where's that headroom come from? You know, the number of cancer referrals that haven't been sent through, you know, the huge drop off in 2-week referrals, but the huge drop off in serious emergency attendants as the ones who would have become inpatients. There's a whole lot of morbidity stored up out there. So if we kind of add together, you know, what does our normal non-elective workload look like with our COVID patients, whatever happens next, the second surge or not the second surge, whatever it is, we don't know, together with the cancer patients that didn't present, all those heart attacks and strokes that just never came in, as well as the... Yeah, well, that's the thing. I mean, the figures are just astonishing. So you have to say some of those people...
And I mean, apart from the heart attacks and strokes, I mean, which I'm not for one moment saying aren't serious, but I mean, you know, when I came up and saw you at the end of the year, wasn't it, last year?
Yeah.
I mean, the place was chock-a-block with people in A&E.
Yeah, 100% occupancy, yeah.
Where have they gone?
Well, we were just looking at the figures for heart attacks just in the meeting. We were just in now 41% of the number of diagnosed, you know, MIs, properly diagnosed heart attacks.
Came into A&E, weren't they? Not just with heart attacks, but with other stuff. Now, you know, we all know a lot of people turn up in A&E because they couldn't get a GP appointment and all that, blah blah.
Yeah, but leaving those aside,
the core of patients there that really needed to be there
just didn't present.
Yeah.
They just didn't present, and we've got, you know, we can see in the figures they didn't present, and so that means there's a load of a part of the excess mortality from COVID has got to be those patients who didn't present with things they would have done in the past, and some of whom may have been successfully treated or not. But there's also morbidity, so people may have just got more ill than they would have been had they presented in a timely way. So we've got to be ready for the fact that we've got that stored up morbidity out there as well. So when you start saying, well, let's get to 80% occupancy and social care is very fragile, it's hard to see how the maths stack up. And when you do the mathematics then of how many of the electives are we going to get through, then you don't get to a very big percentage.
No, you don't. And another question, if I may, just quickly before I move back to the guys, I think there's a staffing issue that we're not thinking about, because there will be a lot of people who've struggled through this.
Yes.
And said, do you know what? You know, I've survived. I've had enough. And when the labour market opens up, they'll go somewhere else. And then the question then is the public. Do they say, I want to join a group of heroes and be like them? Or do they say, you know what, they got no PPE, haven't been able to look after their staff. If you think I'm doing that, you're having a laugh, I'm going to go and find a job somewhere else. What do you think this has done to recruit the future of the workforce?
I mean, you know, you see some positive press coverage about recruitment in that, like, wouldn't you like to join that heroic bunch? But it's a big decision. I mean, you have, again, when you see the coverage, you know, you have to admire the people who are doing it. But for you know, people out there, do they want to join them? Right? You know, is it something they'd want to do themselves? What worries me is there'll be a lot of staff who are just exhausted by what they've been through. There'll be a lot of staff who are almost suffering from post-traumatic stress.
I'm sure they will.
Yeah, and then nobody's taking any holidays, so we've got all that whole kind of backlog of annual leave thing.
Yeah.
So we've got all sorts of workforce issues.
I know, and I tell you what, whatever was in the workforce plan that was never published, I hope they've crossed it out and they're going to start again, I think. Let me just come to you, Rowan. I'm very conscious. John is giving me the sign that we're coming towards the end of our time. And we got lots of questions by the look of it. Rowan, what's the new normal?
The new normal is a blend of face-to-face appointments and lots of technology supporting patients to stay safe and well at home. They need to be streaming us their data so that we can understand and only see those who absolutely need to be in with us.
So that will be the imperative, because previously it was there's the door, it's open, walk in.
Yeah.
Now we've got to change public attitudes.
Yeah, so if we're going to socially distance patients, we can't have 200 people sitting in outpatients. We need to blend our approach and keep being agile. So whilst there's stuff I want to hang on to, there's stuff that almost made it over the line, but I tell you what, for a bit more sophistication and energy, it could work. We're still keeping hold of that bucket of innovation to dip back into it again. So I'm wholehearted for hang on to some stuff, but also re-explore stuff that nearly made it. I think that's going to be very worthwhile as well.
Actually, I interviewed Ed Smith, who was the former chairman of NHS Improvement, a couple of weeks ago, and he was suggesting that hospitals appoint a COVID custodian, someone who looks at everything new that's been done, keeps a list of it so we don't forget what it is, evaluates it and says, this stuff we need to do again. This stuff we need to. I love the idea of a COVID custodian. So, you know, no idea is
held on to through both our Gold Command and our COVID execs. We've got gateways. Nothing is allowed to just pass through and go back to the way it used to be.
That's a really important thing. We can spend all night talking about that. Right, Rob. Okay, for you, the new normal. What is the new normal? I suppose what are you going to do with all this kit that's in all the wrong places?
Obviously, we need to get that back to where it came from. But
wherever it came from.
Yeah, wherever it came from. Yeah, well, some of it.
Some of it.
So yeah, we need to get that back, and we need to put everything back into place. But I think, as you've said before, this next stage is probably more complex than the one that we started with, because actually trying to work with an elective program and bring patients into the organisation, but really ensuring that we keep them as safe as possible. And that we're really sure that
that's your next big headache, isn't it? Social distancing.
It absolutely is.
Thinks about social distancing in supermarkets, and it's going to be in street markets now, and buying a car. But don't anybody's given any thought to how complicated it's going to be to social distance in a hospital where the very nature of hospital is intimate. Let's go to John. What have we got? We've got some questions, John. Can we do some questions, please?
Yeah, we've got masters. I've got to say, it's the highest attendance that we've had on any of our virtual webinars so far. We have nearly 200 people on the call, which is testament to the interest, I think, in what St Helens Knowsley and Anne personally and her team have been doing. So let me go through a couple here.
Can you make
question number one? Yeah, I'll try. I'm going to do that. Several people asking, what initiatives have you introduced to ensure, in particular, the mental well-being of staff during this time?
Is that one for you, Anne, I think?
Yeah, well, we've done, it's never one thing, is it? You know, you need to do loads and loads of different things. So we've got a really good health and wellbeing department who have run all kinds of different initiatives to try and support the staff in every way that we can. So, you know, from helplines to drop-in sessions to people reaching out. We've kind of got everything going on to make sure we do all we can to be supportive. But also, it's not just about those kind of things, is it? It's about kind of trying to keep a reasonable, upbeat feel about the place, and not having it feel like coming into a place that's like depressing and fearful. We're trying to have a bit of fun and keeping it a bit upbeat and trying to do some nice things together as well.
When I came up and visited and walked around with you, it was everybody knew you. You knew people's names, you know, from the porter to right across the organisation. I mean, that's great credit to you, and that's the way to run a hospital. But of course, it really does pay off at times like this, doesn't it?
It does, and we went through.
And trusted.
Yeah, we went through the very sad experience of one of our own staff actually passing away. Just being able to get together with the staff, all of us together, and pay tribute to him that day was, it was really moving, but it was also kind of quite healing as well in a way that we shared it together.
I'm sure. John, back to you.
I've got a cracking question next. You're going to love this. This could be to any of you. How did the reality of the pandemic measure up to the major incident plans and practice exercises that you no doubt regularly went through?
Right, Rowan, this is one, I'm going to go straight to you with this. I can see your eyes glazing over. Tell the truth. This is your opportunity to tell the truth, Rowan.
So there's all that planning and practice in a stale environment. There's nothing like living it. And we've probably been far more innovative than our plan ever asked us to. Our staff have dug deeper into their own personal resources than perhaps a major plan was ever going to ask them to. And standing shoulder to shoulder with them to do that made the whole thing possible. And in amongst some of the very long days where we've run round units, we've literally counted gowns, the amount of transformation that we have achieved that we will keep and hang on to is something that will always stay with us through this, the most difficult and challenging of times. And yet it's allowed us to move forward in ways we perhaps would never have imagined and planned, never thought about.
It's very interesting. There's an old saying amongst planners, I'm sure Anne will have heard this, the nearer you get to the action, the further you get from the plan. And that's
like when you think about it, Roy, we've done all these practices of planes crashing into the hospital and chemical explosions in the local chemical factory. We've done all of those practices, but so our global pandemic actually probably tops all of those things.
An aircraft falling out of the sky onto a signal is easy compared to this. Rob, you must have done the emergency planning stuff as well. And what's your view? Was it different?
Yeah, absolutely. And I think the thing around emergency planning or emergency preparedness, it's about a particular incident. It's about something that perhaps you put the capacity in, you deal with it, and then you de-escalate, and fairly quickly. It's the kind of length of time that this actually has gone through. So the amount of time that we've had to prepare for, the sustainability of the work from the staff and the teams, and then coming out of it, it isn't just about back to normal straight away. This is about a new normal, as we've spoken about before. So it's absolutely nothing like anything that we've planned for before.
Yeah. John, you got another one?
Yeah, I'm going to amalgamate several questions, if I may. A lot of people first of all, a lot of people congratulating you as a trust around what you've done and how you've done it. But the question is, really, how have you managed to achieve the buy-in from everybody in terms of your communication structures, your management structures, and so on? How have you managed to get so many thousands of people all united and following a plan that you're laying down at an exec level?
Well, I think it's kind of, we've just carried on what we did. I mean, obviously our kind of thing is to have a positive culture in the organisation. It was always, the thing that let's demonstrate that, actually being successful is about having everyone bought in, wanting to be part of the team and contributing to it, rather than there being a kind of, a hierarchical structure whereby, we're all kind of exercising power at every level. So I do think at a time of adversity that comes into its own even more. So you do the same things we always did, which is, we do the right things for the right reasons, and the staff see us do the right things for the right reasons. We value and respect them, and above all, listen to them and take on board what they've said. We do everything we can to keep the place as safe as we can, both for the patients but also for the staff as well.
Yeah,
and
I saw that when I came up, and you've had a lot of that in the bank to draw on.
Yeah, it pays its dividends when you're up against it.
It's a lesson in leadership. Right, John?
I've got a great comment that's just come in from a lady. I'm not going to give your full name, Sarah, but Sarah says, I want to come and work at St Helens Knowsley Hospital. What a team. And so positive.
Come on in, Sarah.
That's right.
Just thought I'd share that with you.
Yeah, you know where we are.
That's the John Wilkes recruitment agency just started.
Yeah.
Right.
Great.
Well, so let's finish on a good one. We got a nice one to finish with.
Yeah, we have really. Listen, there's so much positivity around the new innovations and the means of interacting with patients and with staff through the technology. The big question is, how do we maintain that and accelerate it? What's the next thing that we're looking to achieve in that regard, do you think?
Right, that seems a question for operational and performance. Rob.
Yeah, sure. I mean, I suppose, as we'd alluded to before, the main thing is about actually getting people on board with the technology, seeing that it works, not being afraid of it, having that interaction with a patient through something like telehealth. So again, I mean, I suppose this is about getting something in the bank in terms of engagement and in terms of support for that technology. And because we've kind of pushed this through relatively quickly in response to the pandemic, we've actually got a number of people who have gone, well, do you know what, I was a bit of a naysayer before, and actually I've seen it work and I've seen the benefit of that. So that has given us some really good kind of grounding to really motivate staff and move this forward.
Yeah, you can see it working, and I guess the same answer is true, Rob, amongst the clinicians, isn't it? If they can see it work and they feel confident of using it, you're halfway there.
Yeah, absolutely. And I think as we've seen,
forgive me, Rob, I meant to address that to Rowan. I was saying, you know, if clinicians can see it working and they don't feel at risk themselves through making a misdiagnosis or a mistake through using technology, they will use it.
Yeah, absolutely. And it's providing the support that goes with it. So, for example, our telehealth solution is intimately stitched into the whole PAS. So we're recording the fact that we've seen these patients, we're capturing all of the interactions, we generate the letters almost in real time as we're going along through these clinics, and actually are managing to interact with patients in some ways even more efficiently than we used to. The clinicians are well supported in using any of this technology, and the feedback from our patients has been, this has worked really well. The crucial thing is that we still reach those most vulnerable that need to come and see us, that we provide a clean, welcoming, well-organised hospital that will always be open to care for anybody that needs us. And we've got to keep pushing the confidence back into our patients that we are always here for them, even if it's in a way we didn't used to do.
Yeah, I think, and of course, using technology can create the headroom and a space in time and place to look after people who can't use the technology. I think we're up against the buffers of time. Anna, the last word, it's got to be with the boss and the cell commander. So we'll leave the last word with you. What's your abiding memory of COVID 2020?
I suppose the uncertainty at the start. It was a bit one of the things I think about is I always think one of the valuable things about leadership is that I think the subordinates kind of value the certainty that you know what you're doing, and when you're kind of in that place where you think, I actually don't know what I'm doing, because I've never managed a global pandemic in all the 100 years I've been doing this. Yeah. This was a new one on me. So it was a bit like, I was in the unusual position of not being able to say to my team, some of whom are here, well, when this happened before, this is what we did. It was a whole new thing. So I hope we don't have another one. That's all I can say.
It's so refreshing to hear a leader saying, I don't know the answer.
I don't know what I'm doing. Yeah. So
it's a mark of a true leader. Listen, I don't know where you're watching or where you're listening this, but I hope you've enjoyed it as much as I have. The time has just flown by. In fact, I think I've probably overrun the time. It would be right, wouldn't it, for me to say thank you to Rowan and Rob, and of course to Anne and all the team at St Helens and Knowsley, and everyone under the auspices of the Cell Commander, Cheshire Merseyside Hospital. Listen, thank you all for what you've done and keeping us safe. We're enormously grateful and full of admiration, and thank you very much. I just hand back to John for a final word, but thank you for watching, and thank you to our contributors.
Thank you.
Well, it's been a blockbuster session once again with Anne and her team. We are very grateful on behalf of the Institute of Healthcare Management. Thank you to the team. Thank you to the people of Cheshire and Merseyside as well for the support they've given you, no doubt, in the hospital and the structures around this.
Yeah.
all that remains for me to say is, if you're not already a member of the Institute of Healthcare Management, do please go online at ihm.org.uk. We have a special offer on until the end of July. You can join for free. We think it's the right thing to do to open up our content to everybody who'd like to join for free up until the end of July. So that's all from me. Thank you once again for joining us. Thank you to Anne, Rowan, Rob and Roy, and we'll see you next time. Bye-bye.
Bye-bye.
Bye.
Keep safe. Keep safe.